Okay, well, it is noon right now, so I will get started as the rest of the people log in. So good afternoon, everybody, and welcome to UAB Pathology Grand Rounds. Today, we will be hearing from Dr. Ellen Eaton, who's an associate professor here in the UAB School of Medicine Division of Infectious Diseases. She's a native of Dothan, Alabama, and she originally earned her Bachelor's of Science in Chemistry at Vanderbilt before attending medical school here at UAB. She then completed her residency at Stanford, where she served as a chief internal medicine resident before returning to UAB, where she also completed an infectious disease fellowship and a master's degree in public health. Dr. Eaton's patient care and research centers on the infectious consequences of addiction. Her current research tests interventions to prevent and treat HIV in individuals with substance abuse. In addition to all that, she is the founder and director of the UAB 1917 Clinic Opioid Treatment Center, as well as serving numerous public roles during the COVID pandemic, including being consultant to the mayor of Birmingham and as part of his responses to the COVID pandemic. Dr. Eaton has an extensive mentoring portfolio and a just as extensive current funding portfolio, listing funding sources and support from 15 different things, many as consultant, but also those as co-investigator and PI on an NHRO1 and a co-PI on an NIH grant for the Zambia, Alabama HIV alcohol comorbidities program. So a very diverse portfolio. She has over 30 publications and just as impressively, over 35 national press appearances, including ABC News, Reader's Digest, and the Washington Post, and also 30 or more in the local or regional setting, including NPR appearance. And today, with all that background, I will hand the mic over to her, and she is going to tell us about the infectious consequences of the drug use epidemic. Thank you, Dr. Eaton.
Thank you very much. That was so generous. I really appreciate it. And I'm so grateful for the opportunity to speak to you all today. I'll be honest, when I got the invitation to speak, I thought, what do I have to tell our pathology group? Like, what will they be interested in? But I'm hopeful that some of these infectious consequences will be helpful for you in your clinical work and research as you think about how to incorporate substance using populations into your work. But also, I know that just statistically, many of us are going to have a loved one, family member, or friend who has addiction, substance use. We are in the middle of an opioid and drug use epidemic. I'll tell you about some changing trends and how even the opioid landscape has changed. And I'm hopeful that you'll find this interesting. I am going to try to pause between objectives to give some time for questions in the chat. And I've asked Dr. Wendy to speak up if there's anything in the chat that I need to respond to before we move on. We should have plenty of time for questions. So my disclosures, research support, and some honoraria. In terms of objectives, I want to share with you recent trends in illicit drug use, both nationally and then also at the local level. I want to review infectious diseases, epidemiology, and how drug use puts you at risk for certain infections. I call these opportunist infections in substance using populations. And then lastly, I want to talk about addiction treatment as a way to prevent infections and also help us manage infections. So treating the underlying substance use disorder as a way to improve infectious health outcomes. Several of you all probably saw the New York Times publication at the end of last year showing 100,000 overdose deaths in 2021. Those were estimated deaths, and it's thought that it's an undercount and that we likely exceeded that. But that is a historic number, and it's certainly a sad day when we're losing that many individuals to the drug use epidemic from opioid use alone. From overdose alone. This does not account for those deaths that are related to endocarditis and bloodstream infections and all the other things we're going to talk about today. So this is just overdose deaths. And then I want you to see this map at the bottom of the image, which shows across the deep South and up to California, how there's been a more than 50% increase in overdoses in the last year. And certainly there are reasons that predated the pandemic, but then this has also been exacerbated by the pandemic, right? We know that a lot of people with substance use have increased their substance use and have had limited access to care during the pandemic, leading to really just this tsunami of overdose death. Bringing it closer to home, these are some slides from JCDH showing that our overdose deaths have really increased year after year on year from 2020 to 2021, what you can see is that on the left-hand side, you have deaths across the board from January to December in 2020. And as you move to the right-hand side, you can see that these numbers have gone up significantly. So January 2020, we had 182 overdose runs. Sorry, this is not deaths, this is overdose runs. So the EMS being called out. And then in January 2021, we have 221. So we've increased significantly. And the same trend continues across the table as we move across the calendar year. And what does this translate to in terms of burden for our EMS? You see these big numbers, and it's hard to understand what that requires of utilization for EMS and first responders. But apparently, according to our health officials, there were several days in this past December where they were doing 8 or 9 overdose calls a day, which is very labor intensive, especially in a pandemic. If you recall, December of the last year, we were still seeing a fair amount of Omicron. So very labor intensive, has huge public health implications for our community. And then this chart also from our county JCDH data, what you can see in the blue line is overdose deaths per month, and in the yellow is overdose deaths per month. So overdoses in terms of cases in the blue and actual fatal overdoses in the yellow. And you can see the deaths have remained somewhat stable. The actual cases of overdose have been much more inconsistent, up and down, up and down. And again, what this translates to at the county level is an average of 4 ER visits a day for overdose in December of 2021. About 40 deaths in December of 2021 just for our county. And it is notable that this is down from March 2021, down from about 8.4 ER visits a day. So, this is ebbed and flowed, but still contributing to a consistent burden on our EMS, first responders, and certainly our ERs and hospitals that are also dealing with the pandemic. Just more data breaking down what types of drugs are causing these overdoses. This slide focusing on deaths. And what you can see is that opioids, specifically fentanyl, contribute to a large percentage, 291 of the confirmed deaths in the last year were from fentanyl. Heroin was about 66. You can see that cocaine, not as many, but meth was one, contributed to 121 deaths. Methamphetamines, we'll talk more about that as an emerging drug in our community. And just to note, over the last year, this case count really reflects a 21.5% increase in overdose deaths in the last year. So certainly we are seeing a continued rise in mortality. Taking it now to a national level, I just wanted to show a little bit about the types of populations that we're seeing with overdose deaths. So this is national vital statistics data from the US. So this is mortality. And again, as a reminder, overdose death is not the only outcome that matters, but it is unfortunately easier to measure. A lot of the infections that we'll talk about later in the talk, things like skin and soft tissue infections, things like heart and bone and joint infections, may not come to our attention as being related to drug use. People don't necessarily come in and say, I have staph endocarditis because I inject drugs. Often these cases may be missed, especially in hospitals that do not have the resources like UAB. The rural community hospitals may not appreciate that some infections are related to drug use. So although overdose is an important outcome, and certainly we care about mortality, I just want to remind you that there are other very, very bad outcomes happening in the community that we probably underestimate. But when it comes to overdose death, this national data set reminds us that males continue to have a higher death rate per 100,000 in terms of overdose data, and that the trend is unfortunately increasing. But women are not spared, especially with opioids. We're seeing a lot of women, a lot of young women, a lot of pregnant women, unfortunately, who are affected by the opioid epidemic. And looking at overdose deaths specifically related to opioids, which is a big driver of mortality, what you can see is that synthetic opioids are really driving this trend, excluding methadone. So that includes fentanyl, carfentanil, sufentanil, these other synthetic fentanyl analogs are really driving this trend. You can see heroin continues to be a problem, as do synthetic opioids, semi-synthetic opioids, but really what's causing this steep upward climb in overdose deaths are these synthetic opioids. Stimulants, as I've alluded to before, is really, I said emerging, but this threat has been here for a while, and I think we're really just beginning to quantify it. I highlighted here on the right-hand side a book that I just read that I highly recommend if you're interested in learning about the history of fentanyl and meth in our area, especially by Sam Quinones, who also wrote Dreamland, a New York Times bestseller. It really gives a narrative behind this really wave of the drug use epidemic. But what this chart is showing you is just that cocaine and methamphetamine specifically, this psychostimulant category in green, are also continuing a steep upward climb, really predating the pandemic. But we anticipate that this climb has continued during the pandemic, even though we've had a lot of barriers to quantifying and surveying meth use because of the stress of COVID. I can imagine that when we update these numbers, 2022 and beyond, we'll see that the last few years have been really devastating for meth-related overdose deaths. And when I say stimulants, just to make sure everyone understands, stimulants, the most common being methamphetamines, amphetamines in general, cocaine, crack cocaine. And when I say opioids, just as a reminder, that can include pills, oxycodone, hydrocodone, Vicodin, Percocet, but also heroin, fentanyl. And the two, unfortunately, are treated very differently. And we do not have as many treatment options. We don't have any pharmacotherapy for stimulant use disorder. So that's a huge problem here because we have very little to offer our patients in terms of treatment for stimulant use disorder. And it's a very, very fatal substance use disorder as a result. So bringing it locally, this is data thanks to Dr. Brandy McCluskey, one of your colleagues, who's been very helpful and a great partner for me. And what it shows is that our local data really mirrors the trends nationally. And again, we anticipate that beyond 2020, these numbers will continue to rise, but will take some time to quantify the last couple of years. What you can see is that in purple, cocaine, an old consistent challenge for us, has been going on for decades, especially in my patients with HIV. Heroin in the turquoise also has been around for quite a while, has somewhat flattened out in terms of overdose deaths. This is death data. But what you can see in the orange is that fentanyl is really coming up starting in the last 7 to 8 years, continues to be a challenge. This is a synthetic opioid. And then meth in green. Remember, we just talked about that, methamphetamines as a stimulant. And these are often used together. So I have a fair number of patients whose drug of choice is opioids. Remember, opioids often cause euphoria. They can make people relax, kind of chill out. And patients will often self-medicate with methamphetamines to keep them awake, to get ready for work after they've used opioids or had a long night. They'll use meth to wake up. And I've heard the analogy, and I certainly see it in my patients, it's like wine and coffee. So the opioids being like wine to some people and the stimulants being like their coffee. And I have a fair number of patients who are young, healthy, somewhat healthy, functional patients who get off the construction job at 3 o'clock. They go use, heroin, whatever their opioid of choice is. And in the mornings, they'll use a stimulant. They'll go back on the job site. So they are self-medicating. And this is very, very dangerous because if you're using a stimulant in combination with your opioids, you can use more and more opioids and you can more easily have a fatal overdose. And that's what we're seeing in this data. There's a fair amount of polysubstance use and multiple substances in these fatal overdose deaths. And bringing it to our county level again, what you can see in terms of opioid deaths in Jefferson County, comparing basically January 2019 to June to the same period in 2020, so 2019 to 2020, even pre-pandemic, you're seeing a 33% increase in opioid deaths, a 22% in total overdose deaths. So you can see overall an increase, and a large part of that is related to opioid use. And then bringing it to the hospital level, this is kind of gets into my population of interest, these patients who inject drugs. So at the tip of the iceberg, these patients have high risk for morbidity with infections because they are often using shared needles, unsterile needles, unhygienic practices, getting bacterial infections. And when we sample them and query them on their drug of choice, it mirrors the data nationally and the overdose data, which is that opioids are the primary offender here in terms of our local epidemic, but a fair number also use methamphetamines. Fewer use cocaine in my experience. Again, this is patients who inject drugs, and cocaine is less popular in terms of drugs of injection. If I looked at a sample that just used street drugs in general, I'd say crack smoked is still very common in Jefferson County, but that is not an injecting population, and it matters in terms of infection risk, right? And then a fair number, about 30% who inject, are injecting more than one category. In our experience in the hospital, it's primarily opioids with a stimulant, with methamphetamine, that patients are using together again, that, you know, at times, not always, I don't want to overgeneralize, but we do see a lot of that coffee and wine, self-medicating, prolonging either the euphoria or recovering from a long night, a long day with a stimulant going to work. So I can pause there. I don't know if there's any questions in the chat or if anybody wants to raise their hand or ask a question. No.
There are none in the chat yet, so I think you can keep going if there's any. Great. Thank you.
Yeah, so now I want to talk to you all about the overlap between addiction and infection. A lot of the data I'm going to share is in the hospital setting, and the reasons for that are complex, but a majority of our patients who inject and use street drugs are uninsured, more than 50% in the Deep South. We do not have Medicaid expansion, so these patients often do not have a primary care clinic. So they let their skin and soft tissue infection fester, or they may let their fever and bone and joint pain fester until they're sick enough to go to an ER. Once they're here, often they're very sick and they end up in the hospital. Now, this data is a national database called the Healthcare Cost and Utilization Project. I just looked last week. They do not have updated data for the last couple of years, but what you can see is that opioid-related hospital use has increased and is quite high, representing, you know, around 300 out of every 100,000 patients hospitalized. The population that I see and that comes to our attention most, because they are so sick, are these patients with what we call SIRI, which is an abbreviation for serious injection-related infections. So unlike the trauma patient who may never disclose that they use opioids unless they go into withdrawal, or unlike the patient delivering a baby who it may not come to medical attention that she has opioid use disorder. If you have, you know, a bloodstream infection, an endocarditis, a wound from injecting, you're more likely to come to the attention of your medical providers as someone who possibly uses substances. And I bring this up because I do appreciate that we don't understand the full breadth of opioid use in our hospitals. But this group frequently comes to our attention. I could say we have about 120 patients like this at UAB every year. And here's the breakdown of what we're seeing them for. Endocarditis in the bright green, vertebral osteo and abscess here in the even darker hunter green, the bright green being osteoarthritis, bone and joint infections, bloodstream infections in yellow, and in tan, the skin and soft tissue infections. This is their primary reason for admission. Sometimes they have more than one of these. Sometimes we think they have just a bloodstream infection, and on further workup, we find they have endocarditis. And I also want to bring up that these chronic infections often go hand in hand, HIV and hepatitis C. So we know in our most recent review of our patients, about 73% have hepatitis C and 4% have HIV. I should mention, we all think about these infections as being injection related. However, it's a lot easier to transmit some of these viral infections via transactional sex, high-risk sex. And so often we'll have patients who have injection drug use, but we know from their history and their, you know, practices, you know, maybe they're a sex worker, maybe they're, you know, having multiple partners. We often see sexual transmission being the driver of these infections in patients who inject drugs. I'd say the people who most efficiently transmit HIV via injection, which we know happens. We know it happened in the Scott County, Indiana outbreak and several outbreaks across the US in the last 5 years, is when you have someone with acute HIV. And when you have acute HIV, it's very, very easy to transmit HIV through a needle. But for those patients who inject drugs with chronic HIV, harder to share HIV through a needle, easier through receptive anal sex, for example. So tricky to tease out how they get it, but just know that these types of viral infections go hand in hand with this patient population. And we screen for them. And at UAB for quite a while, as long as I've been here, we've been doing universal screening of HIV and hepatitis C in this patient population, which is key. I also like to frame addiction-related infections as opportunistic infections, much like HIV. You know, we're always taught about the infections that go along with HIV are because that patient is a different host. They often have a low T cell count, which puts them at risk for X, Y, and Z infections. We know that patients who use street drugs also have certain behaviors, right, that put them at risk for various infections like endocarditis and hepatitis C, as I shared. So that's how I remind my trainees and colleagues to think about these patients. Know that just like your patient with AIDS may have PJP, know that your patient who injects drugs may have hepatitis C, may have endocarditis, may also have syphilis for the reasons that I just mentioned around sexual activity, transactional sex, survival sex. What this data from North Carolina shows in this morbidity and mortality report is just that across all age groups, drug-related endocarditis is going up. And again, this was published in 2017, so it does not include most recent trends, but even prior to the pandemic, what you can see is that in that 26 to 40-year-old age group, the number of endocarditis cases in patients who inject drugs in North Carolina really started going up really around 2014. And you can see also in the 18 to 25-year-old age group going down, and even the group over 60 is seeing an uptick, which I think is interesting. I very rarely see these patients in the hospital. Usually I'd say my patients are 30 to 40. They usually start with pills in high school or young adulthood, either from a sports-related activity, a car wreck. They become dependent on opioids, and somewhere around 20s to 30s may transition, make the pill to needle transition, start injecting. And often, you know, within a couple of years of injecting, they have a significant serious injection-related infection like endocarditis, which we know is universally fatal if not treated. This is from a national database, similar data. This is from the Premier Healthcare Insurance Database looking at infective endocarditis in substance use versus not substance use. And their data is just a little different. In the older age group, it looks like the injection or infective endocarditis in substance users that are over 65 is staying flat, but in the 18 to 44-year-old age group, really going up. And then endocarditis that is non-substance use disorder staying flat, which we would expect. So a big driver of a very morbid infection. And then I want to remind you that this serious injection-related infection, although they come to our clinical suspicion a lot for the reasons I mentioned, they're often very, very sick. They may need prolonged hospitalizations, surgery for a valve, a joint. I really think they're just the tip of the iceberg. We often will not screen them for things like syphilis, TB. There's a whole host of other infections. We have had a rash of acute hepatitis A. Some of you all may have been involved with those cases in the last couple of years. And I think we still in Jefferson County meet criteria for epidemic levels of Hep A. And so certainly this population needs to be vaccinated against Hep A. We screen for Hep C routinely at UAB, but doesn't consistently happen in the outpatient setting or in hospitals outside of UAB. Hepatitis B is common in this population. I'll say that we see less of that in the Deep South, but there are certain substance using populations, California, Rhode Island, more urban areas that have more of a problem with hepatitis B in their population who uses drugs. We talked about HIV, a fair amount of STIs. This group, as I mentioned, does not have access to routine healthcare. They're not routinely showing up at primary care offices, even county, low barrier STI clinics because of their substance use related behaviors and because of stigma. criminalization. They're not necessarily going to show up and say, hey, I use heroin 5 times a day and have transactional sex to come to your attention that they need to be screened for STIs. So it's something that we have to have a high clinical suspicion. And when I'm on the hospital service and I'm seeing somebody for endocarditis, I often will leave in the chart, make sure they have HIV, Hep C screened, offer a Hep A vaccine if possible, and recommend that we go ahead and screen them in the hospital. But that's certainly not routine practice. And unfortunately, a lot of that just doesn't happen for a range of issues. They're not insured. So who's paying for that if we do offer those comprehensive services? And frankly, when somebody's very seriously ill with a bacterial infection, the primary team is worried about cardiology's rec for replacing that valve and endocarditis, and they may kind of poo-poo your recommendation to check syphilis. But I'll say, even in the hospital, I've picked up a fair number of syphilis cases on these patients. I'd say probably 3 in the last year, who just on screening had syphilis, but were here for a bacterial infection. We know the Deep South has a syphilis problem. We know Alabama has a gonorrhea chlamydia problem. Statistically, somebody's going to have it in the hospital. And if you don't catch it and treat it in the hospital, they may not show up again. Interestingly, if you don't check them for bacterial STIs, they're probably going to get broad spectrum antibiotics and get treated. But for something more serious like syphilis, you really need to know and treat them appropriately, because we know that can progress to neurosyphilis. So lots of reasons that we miss those STIs here. This chart I showed you before, but I just wanted to use it as a moment to pause, and as we think about addiction and infection, just show you specifically what we see in our population. So for opioids, the type of infections they're going to have are related to injection, transactional sex, insufflation, less common, but you will see for patients who are insufflating or snorting their heroin, they can have sinusitis, they can have issues with their septum, necrotic tissue there. Occasionally I'll see a sinusitis. For methamphetamine, I see a fair number that smoke and inject. Classically, meth is associated with chemsex because it is a stimulant. People are disinhibited. It is a party drug. I've been told by some of our stakeholders in the African-American community that it's pretty common in the MSM community, men who have sex with men of color in Birmingham. I think my understanding is that is more smoked in that group, but think about STIs in that group, and certainly HIV. Cocaine, I don't see this injected much in our data here in the hospital. Most of the injection of stimulants is meth, but I will say crack is still a problem here, and we still see a ton of transactional sex with crack use, and just recreational sex, high-risk sex in general. I see the classic infection I see with crack use is trichomonas in a 50 or 60-year-old woman. I see a lot of STIs there, and certainly HIV as well. I want to remind you that opioid injection is a barrier to ending the HIV epidemic, and we don't classically think about that. We don't classically think about HIV prevention or PrEP for poor rural communities that are ravaged by opioids. We just don't. We think about other priority populations, which are important too: young Black men of color, women of color in the Deep South, huge priority for ending the HIV epidemic. But there's been a recent focus on this just because we have seen so many HIV outbreaks in populations who inject. So I mentioned Scott County, Indiana. We've had them in Oregon. We've had them in Massachusetts. We've had them in West Virginia. So a huge barrier to HIV, and these populations meet criteria for HIV prevention and PrEP. Opioid injection is an obstacle to ending the Hep C epidemic. We know we have a Hep C problem in Alabama, and certainly at UAB, we see a ton of it. This data goes to 2017. Sorry, this image got cut off, but just to show on a macro level from CDC data, Hep C cases are really going up. This is acute Hep C, which is just the tip of the iceberg. We know we see a lot of chronic Hep C. And this figure on the right, it's really heartbreaking to me because it looks at Hep C positivity amongst all adults in this lavender color, but the dark purple is in pregnant women. So like if you look at the prevalence, 3% prevalence in pregnant women in West Virginia have Hep C. Tremendous implications for the mom, but also for maternal to fetal transmission. We really still don't know how to manage these patients and their children at a systems level, especially in states that don't have Medicaid expansion. We know these drugs that treat hepatitis C cost $84,000 for the course. So a huge problem for Deep South, rural states without a lot of public health infrastructure like ours. And then I wanted to bring this up because we're starting to see more attention at a national level on the importance of really integrating addiction treatment and infectious diseases treatment. So integrating care so that if you have a patient who comes to your clinic for an STI, you're thinking about screening them for substance use and offering them treatment. Or if they come to your addiction clinic or your ER because they just overdosed, you're thinking about screening them for HIV and Hep C. And it's a really important way to get access to this population who's really hard to reach. For those who are just interested, I think this is a really great summary that the CDC has put together. And frankly, I think, as I mentioned earlier, if our patient population isn't affected, statistically, someone on this call is going to have a friend or family member who is affected by the opioid epidemic. And a really nice summary of the data and best practices on not just how to treat the infections, but how to prevent them. For those of you that followed the Scott County, Indiana HIV outbreak, you know that the syringe service programs that were put into place really when the HIV outbreak hit a fever pitch were wildly effective. As soon as the patients in their community were given sterile syringes, HIV cases really plummeted. We don't have syringe service programs in Alabama. Many states in the South do not have access to sterile syringes. These are the populations that are most at risk for an HIV outbreak. All right, and I'll pause here after that addiction and infectious diseases. If anybody has questions about the epidemiology or what to look for in which groups, I'm happy to answer them now, or you can we can wait for later.
Okay.
All right.
I think people are waiting for the end.
Okay. All right. So lastly, we're just going to talk about how addiction treatment is infection prevention. So thinking about treating the underlying psychosocial risk factor in order to prevent disease, but also if you're already infected with that infection, we know that stabilizing your addiction will increase the chances that you'll reach a cure or reach your ideal outcome, regardless of that infectious disease. So I mentioned this a little bit earlier, but harm reduction is the notion that many of our patients are going to cycle in and out of drug use. We certainly don't encourage that, and we're trying to get them into recovery. However, what can we do in the interim to prevent them from morbidity and mortality if we know they are likely to use again? We know about buprenorphine, which is also known as Suboxone, when it's co-formulated with naloxone, highly effective at reducing overdose, death, reducing substance use, reducing HIV, reducing hepatitis C, highly effective. We just talked about sterile syringes. There are also safer injection practices. If you're going to inject, can you sterilize your needle with bleach? Can you inject in an area that is not as high risk as your neck or your groin, which are very high risk for infection just based on their location? Can you use bleach or alcohol swabs? Condoms, harm reduction. We know this population is high risk for HIV and Hep C and STIs. Testing is a harm reduction, as I mentioned. Maybe you don't have training to treat their addiction. Maybe you feel like you can't offer anything else, but can we look for some infectious diseases? Can we vaccinate them? Can we give them naloxone, which is an overdose reversal for opioid overdose? Highly effective. I always tell my patients, if you're using, please don't use alone. Nobody can help you. Make sure you have your naloxone. We train at 1917 Clinic. We train a caregiver, a loved one. This is what naloxone is. Here's how to know if your loved one has overdosed. Here's how to use it. Call 911, then use it. But if patients are never using alone, it's less likely they're going to end up dead. And then fentanyl test strips, you all will hear more about this because there is legislation in Alabama to get access to fentanyl test strips out in the community. I have a fair number of patients who use non-opioids, or they think they're getting crack, or they think they're getting marijuana, or they think they're just getting heroin, and they get fentanyl, and then they overdose. And so this is a harm reduction policy that patients can know if their drug is adulterated with fentanyl, which is super, super potent. And frankly, we're seeing fentanyl overdoses in kids who are buying counterfeit benzos on TikTok. I mean, we hear about this even in Jefferson County, teens who are buying counterfeit benzos, counterfeit Percocet on social media apps that are adulterated with fentanyl, and the mom goes to wake them up for school the next day and the 16-year-old doesn't wake up. So lots of reasons that you should have fentanyl testing in the community to prevent these overdoses. This is a slide from Canada. Just a slide as an example. Canada has had a heroin epidemic that has predated ours, and they have a lot of harm reduction. It's very interesting. A lot of their harm reduction is around inhalation, just thinking of the types of drugs and the ways they're used, thinking about preventing debris from entering your lungs, kitchen foil that won't be toxic to your lungs. So I just put this up as an example because harm reduction goes far beyond what we use in the US, and other communities and countries have used it in ways that are very different and have predated us by decades. So that's from British Columbia. And I also want to show the results that some of these Canadian communities have had. So here's one of their harm reduction campaigns. You can see they had naloxone, harm reduction supplies, needles distributed, condoms distributed, methadone maintenance. And in terms of results, you can see 55% decrease in Hep C, 78% reduction in HIV, overdoses reversed. I just highlighted the infections because, you know, I'm an ID doc, but look at all these amazing outcomes. People getting admitted. I mean, that's the other thing. Harm reduction allows you to integrate your services, right? If you have a syringe service program, a lot of people provide syringe services, but they also have patients coming to pick up their PrEP or coming to pick up their HIV treatment, their Hep C treatment, get their syphilis treated, get their Narcan to prevent overdose. So harm reduction does create a space and a venue to integrate infection and addiction services. For some, addiction treatment is not abstinence. And I just want to bring this up because I do have a lot of patients who are cycle in and out of recovery. They'll be in recovery for 6 months and then their mom died of COVID. And then they start using, or maybe they cycle in and out, you know, once a month, twice a month, depending on the substance. Well, even if you can reduce their use, you can improve some of their infectious outcomes. So what this graph is showing abstinence versus just a reduction in use. And across the x-axis is the likelihood of reaching undetectable viral load for HIV. So HIV suppression, the likelihood of HIV suppression. And you can see abstinence moves you across the x-axis for a range of drugs, but reduction, just reducing your opioid use, just reducing your meth use actually leads to significant increase in the likelihood your virus will be controlled. And it kind of makes sense. I mean, if you just are cutting back on your substance use, your life is more stable, you're more likely to adhere to your medication, which down the line, the downstream effect is that your virus will be controlled. And that has important implications for transmitting HIV, right? If the goal is to end HIV, everyone who uses substances, their virus has got to be undetectable. So even reducing their use can help us get there. Missed opportunities for harm reduction. This is a lot of the research that I do, which is thinking about how to keep people in the hospital safely for long enough to treat their endocarditis, to treat their bone and joint infection, to treat their brain abscess. Because what we know is that if they leave prematurely or they elope, they're going to end up back. These are severe bacterial infections. We know that 30% of hospitalized patients who inject drugs leave prematurely. The data shows that there's a lot of stigma, a lot of criminalization. There's a lot of language in hospitals that makes it untenable. Things like pain-seeking, drug addict, junkie, things like that that create a culture that is untenable for our patients. We know that more than 10% of patients who leave UAB after one of these series are dead within the year. And we know that stimulant use, so patients who inject stimulants have a very, very high risk of death. And we talked about that earlier. There is data on how to keep people in the hospital long enough to treat their endocarditis, long enough to get a new heart valve, long enough to get the amputation they need for that necrotic foot. We know it starts with addiction treatment, getting their substance use under control so they're not withdrawing, right? If you're in withdrawal, you're not going to hang around. Peer recovery coach or people with lived experience with substance use. We have these staff on hand who are in recovery, have a history of drug use, and they're excellent counselors and educators for our patients. They can come to our patient's bedside. They help us create a very patient-centered approach. And then we know case management is really important as well. So thinking specifically about the addiction treatment that we can provide to improve infection treatment and prevention, we have 3 FDA-approved meds for opioid use. As I mentioned earlier, meth use, stimulant use, much harder. We don't have good pharmacotherapy. For opioid use, we do. We have buprenorphine, which many of you may have heard of Suboxone. That is buprenorphine with naloxone co-formulated. We have methadone, which has been around forever. And we have naltrexone, which is an antagonist, an opioid antagonist. Not favored because the minute patients stop using it, they free up their opioid receptors. They're opioid naive. And if they return to care, they are much more likely to overdose. So I do not use a lot of naltrexone unless people have just failed other things. I'll refer my patients to addiction medicine to do naltrexone. And then, as I mentioned earlier, if they have stimulant use disorder, we don't have great pharmacotherapy for that. I get addiction medicine on board. If I don't have if they're leaving the hospital, I'll refer them to outpatient addiction, and I'll consider getting a peer involved, a staff with lived experience with substance use. So thinking about the medications we have, this addiction treatment improves infection outcomes, reduces HIV, reduces Hep C. If you already have HIV, Hep C increases the chances that you'll take your meds and control your HIV and cure your Hep C. And then we know that by reducing your injection frequency, you're less likely to get these serious infections. This is a hospital study from WashU. One of my colleagues, Laura Marks, looked at hospitalized patients with serious infections, and she just did a retrospective chart review to see were they on any meds for opioid use disorder, and did that affect their outcomes. So again, these are addiction interventions. These are meds for addiction that improve infectious outcomes. So what she found was any of these meds, including a methadone taper, which is not a maintenance, but a taper off the meds, reduced premature discharges or elopements significantly, increases antibiotic completion, so increases the chances that patients finish their vancomycin, their ceftriaxone, whatever they're on, and reduced readmission at 90-day. All met statistical significance. So again, treating the addiction improves these infection outcomes. And these are costly admissions. So reducing readmissions is a big deal for health systems and hospitals. And then this is a violin plot showing those meds again. And what you can see on the y-axis is percent of inpatient antibiotics completed. Again, these patients are often on 2 or more antibiotics for weeks at a time for these serious infections. What you can see is each dot represents a patient, and on buprenorphine, which many of us know as Suboxone, many more patients completed their antibiotics. Methadone maintenance, many patients got there. Methadone taper, fewer got there. But with no therapy, you see a lot of people, with no addiction therapy, many people did not complete their infection therapy. Addiction consultation, if you think of addiction consultation as an intervention, seeing an addiction doc actually increases the chances you'll get meds, you'll get your Suboxone, you'll complete your antibiotic therapy. So again, your addiction consultation increases the chances, makes you 5.5 times more likely to complete your antibiotics, and significantly reduces your chances of leaving prematurely or eloping. So another example of how treating that addiction is really important. And readmission, getting that addiction medicine consultation, this group in blue, much more likely to have a readmission-free survival over 90 days than their peers who in red did not get an addiction medicine consultation. And we're lucky at UAB because we have addiction medicine consultation. A lot of the hospitals in rural communities that are really struggling with meth and opioid epidemics do not have a psychiatrist or addiction medicine trained physician who's willing or able to see patients in the hospital and get them on buprenorphine or methadone. So we are very fortunate here. We've had something called IVAT at UAB since 2016, which is an integrated consultation service. We have an addiction medicine doc, we have an ID doc who sees the patients, discuss the plan of care, and really focus on discharge. When is it safe to discharge the patient? And just integrating these services has increased the number of patients who leave the hospital on appropriate meds for opioid use disorder. We are not where we need to be. We went from 29 to 37% of patients leaving the hospital on appropriate medication. It was a significant improvement, but this continuum shows that of hospitalized patients who inject drugs with opioid use disorder, if 80 of them had opioid use disorder, only less than half of them left with the appropriate treatment. So we have room to improve here, and we're working on that. But the goal would be that certainly 100% of these people leave on treatment to prevent those outcomes. I mentioned integration, and this is something that you all may be involved with on the hepatitis, specifically around HIV and hepatitis C screening. At UAB, we have been screening all ER admissions for universally for HIV and Hep C for some time. As I mentioned earlier, all patients who inject drugs should be screened for hepatitis B, C, and HIV. We don't do it as much for Hep B just because our epidemiology here, we don't see it as much, but certainly should be done. And then people who use street drugs, even if they don't inject, are at risk for hepatitis A. And you all remember this, that hepatitis A, unlike the others, is fecal oral. So anyone who is unhoused or has poor hand hygiene, living in a shelter, living on the streets, even if they don't inject, they meet criteria for vaccination against hepatitis A. And people who inject should be vaccinated against hepatitis B. In talking to some of my colleagues about what I could teach our pathology colleagues, several of them mentioned hepatitis C as an opportunity to improve care in the hospital. Several of them mentioned that for patients who test positive for hepatitis C on an antibody test, reflexively doing genotype testing just so you can expedite their time to treatment. We don't do that here, and frankly, we have a big drop off in our care continuum for hepatitis C. As I mentioned, about 70% of these patients have hepatitis C. We have low barrier resources at the Jefferson County Health Department to treat their hepatitis C. Hepatitis C is curable. We have high success rates with our hepatitis C treatment, which reduces cirrhosis and all these other bad outcomes from hepatitis C. But if you're not a Jefferson County resident, which many of our hospitalized patients come from around rural counties, Jasper, Walker County, Talladega, we see them from all over, then it's not as easy for them, and their local health department may not have funds for hepatitis C treatment. So we don't have a great model or system in place to cure Hep C, but it is, certainly an opportunity to diagnose them, which is that first step in the care continuum. And then we really have room to improve as a community on treatment. And then, obviously, linking them to HIV care if they are HIV infected, hopefully is easy for you all and anybody getting care at UAB because of the 1917 clinic. And we are able to see people pretty quickly after their diagnosis. When they leave the hospital, we're able to meet them in the hospital, introduce them to the clinic and some staff, and make that appointment pretty soon, within a week usually, for new HIV diagnoses or re-diagnose. So someone with HIV out of care who needs to be relinked. There are opportunities in the community, as I mentioned, a lot of things that many of our communities in the Northeast and California and other more urban areas have hubs for harm reduction, for sterile syringes, for education, for treatment of HIV and Hep C. But there are huge policy barriers to that. And I mentioned the fentanyl test strip will probably be the first thing that's approved in Alabama. There previously was a sterile syringe legislation on the docket here locally in Alabama. I think my understanding is, just with the politics of COVID, that a lot of that legislation politically is thought to be not likely to be passed at this time. So hopefully at some point that will be approved. And my understanding was the legislation was going to start with a pilot in Jefferson County, thinking that if the rest of Alabama was not ready to start offering sterile syringes, maybe Jefferson County could. And certainly we have the population in Birmingham. We have the population that's at risk for HIV and Hep C. But I don't think that we'll see that for many years to come, unfortunately. And, as I mentioned, integrating PrEP opportunities to really integrate PrEP in the community. That is not being done There are policy reasons for that, funding barriers for that, but certainly a need and a future goal for my work as well. And then I wanted to bring your attention to this statement from the National Academy of Medicine. It's a consensus report that really outlines the importance of integrating responses. We do have a dual epidemic, opioids and infectious diseases. I think now people say opioids is kind of the out of date term because we really have a drug use epidemic. We have meth, we have all these other substances that are being used. And thinking of ways that we can integrate services. I think, our laboratory is doing a lot of this here. So for those of you who have been involved with Hep C, HIV initiatives, providing that to people who overdose and end up on our ER, that is integration of care. That is providing infectious disease screening that would not otherwise happen at an urgent care or hospital in the community. So we are definitely championing that, but just thinking along the care continuum, how can we use these touch points in the hospital to integrate care is really the way that we're going to improve outcomes and end these infectious disease epidemics. So in closing, synthetic opioids and stimulants are really our big challenge. They're on the rise. They're increasing these bacterial infections, HIV, Hep C, I mentioned STDs, a whole range of infections. Addiction care, including harm reduction, can prevent these infections and increase the chances that our patients who are already infected with HIV, Hep C, et cetera, endocarditis, will complete their treatment and reach a cure in some situations. And then lastly, integrating care is really the key to reach this hard to reach population who does not traditionally have access to care. So that is all. And I thank you for the opportunity to share, and I hope I was able to teach you something.
Thank you, Dr. Eaton. So we have one question in the chat. Are you aware of any increasing multi-drug resistances developing within the IV drug user endocarditis patient populations, maybe as a result of recurrent hospital admissions?
I'm not aware of any MDR pathogens in this population. We did hear from actually the woman from WashU that I shared her data earlier, presented last year about the specific staph species. She did some genotyping on the staph that was specific to the patients who inject drugs in St. Louis that was different, and it was weaker than what she was seeing in non-substance using populations, but it was not more resistant, and I'm not aware of that. I know that one of my colleagues who's relatively new ID faculty, Juan Calix, is interested in exploring that. And I've told him, we have a patient population here. We see about 120 patients like this a year. So if you're interested from a clinical or a research standpoint in looking into that, we could easily query that either prospectively. Certainly, I know a lot of these samples aren't kept for long periods of time. I was going to say retrospectively, but I'm sure we don't keep these, staph blood specimens from bacteremia cases, but we do have a captive population if you're interested in looking into this. And I don't think there's evidence to date on that.
Great, thank you. We have a series of other ones. If people do want to turn on their camera and ask, they can do that as well. Otherwise, I'll continue reading. Okay, so the next question is, do you know how many of the persons in Jefferson County that die from an overdose were known as patients for drug use disorder during life?
So that's a really good question. And at one point, we were thinking about doing a manuscript on this because Dr. McCluskey had data that the vast majority of overdoses in Jefferson County had a UAB MR number and had been seen in our health system within the 6 to 12 months before they overdosed. And that was a lot of the impetus behind state level initiative we're doing to do like a natural language processing algorithm where we can use AI to identify patients who use specifically opioids that are admitted so that we could, if they're not comfortable disclosing, have a fentanyl problem, that we could, maybe offer some counseling or do additional screening, prevention, give them Narcan. So I'm kind of talking around your question. We know that a lot of the ones who died in recent years have accessed our health system and they weren't getting addiction care. They were coming to our, medical services, ER services. So yeah, I think we we're not meeting the need. And frankly, we just aren't, I mean, we have like 4 addiction medicine docs for this huge, 2 hospitals, all the clinics. That's how me as an HIV doc is prescribing buprenorphine now, right? Because we don't have enough providers.
Okay, thank you. So the next question up is the fentanyl abuse and overdoses. Are those due to pure fentanyl or fentanyl laced drugs? Any way to tell them apart, or does it even matter?
So my understanding, and I don't know if Dr. McCluskey has this data, but my understanding is that it's a lot of polysubstance use. And frankly, that's what I'm seeing in urine drug screens on my patients. So my patients who have opioid use disorder, who are on buprenorphine, we do serial urine drug screens to make sure they're taking the buprenorphine. And frankly, sometimes they're surprised that I tell them, hey, do you know there was fentanyl in your urine? And there's also marijuana. And they're like, oh, well, my friend gave me a joint. And, they had no way to know that there was fentanyl. So I think that is reflective of what is going on in the community and leading to these deaths, that people are, they think they're getting crack. They think they're getting heroin. Mostly they think they're getting heroin. And then they're getting fentanyl that is, multiple factors more potent. And they don't even know what hit them,
Well, so Dr. Markey, I see you unmuted. Did you want to give your words of praise, or do you want me to read them?
I just want to say that this is at the same time inspiring, but so worrisome. And there's so much that needs to be done, that we appreciate all your enthusiasm and your skills, because this is a major problem, and it's wonderful to see somebody so involved and willing to take on such a major problem. Ellen, thank you.
Yeah, thank you. I mean, again, I'm flattered to be here. So, and I'm always looking for collaborators.
I definitely echo that.
Well, I'm going to mention to some of not everybody in my medicine was able to attend, but some people could collaborate with you for sure.
Yeah. And it looks like someone commented that most overdose deaths in Jefferson County are mixed fentanyl plus another drug. So that's pretty consistent with what I'm seeing with my patients who are alive still using, is that it's a potpourri of drugs, and they may or may not know what they're getting. Certainly, I'm sure there's some who don't necessarily want to disclose that they were interested in fentanyl and got what they wanted. I think the vast majority were surprised by that. And one thing I didn't mention specifically, that one thing we're doing at 1917 is anybody that uses a street drug is getting Narcan. For that reason. Oh, your drug of choice is cocaine? Great, here's your Narcan. Now, Narcan does not reverse cocaine, but should you get opioids in your cocaine or your crack, here's the Narcan, and you need to train someone that you're with, someone that uses with you, on the use of Narcan. And I have so many patients that every time they come in are asking for a Narcan refill, and they're not using, they've been in recovery, but the community knows to come to them. They know to come knock on my door because I have Narcan. Their friends and family don't have insurance, don't have, access to medical care. And so my patients who are in recovery are basically, the Narcan supply for their community. And it's, these homes where multiple generations are living together, the teenagers are using, grandma's using. It's really devastating. So
how available is Narcan? Do you have an unlimited supply?
Great question. So the state health officer, Dr. Scott Harris, has written a blanket order so that anybody in the state who wants a Narcan can go to a drugstore and get it. They have to pay for it. And in terms of some of our nonprofits in the community can give free Narcan, but the main was at the Jefferson County Health Department. In fact, anybody on this call who's interested in getting a Narcan, I can email Adam the link. Jefferson County, you can do a free, free. It's also an easy PowerPoint video online, and they will mail you your Narcan. So, we should all, my fellows have reversed overdoses in the parking lot. In and around UAB, we should have it on our person. And so I'll send it to you, and you can do the training, and they'll mail the Narcan to you. I hate to say it, if you have a teen or young people that are experimenting in your community or neighborhood, somebody may need it from you from that situation as well.
Great. As the hour comes to a close, you had one final question that popped up, which is actually similar to the one I had in my head. For those who are non-clinicians like myself, what type of policy reform is it? Would you suggest us help to move forward so that these activities can actually have an impact? And the specific question was, how likely is it that the safe locations and distribution will actually be passed, particularly in a state that's sometimes mixes politics and religion?
Yeah, I mean, we were hopeful pre-pandemic about the syringe service being passed. That in and around, even if we just had it for Jefferson County, I mean, it had gone up through the legislature a few times and there was some resistance, but the thought was that it was just going to pass and people would be distracted by other policy. But my understanding is that the Jefferson County public health officials who were pushing it were, so discouraged by the attacks on public health type policy related to COVID that they didn't feel like it's a good time to, that they didn't have the political capital to sacrifice on a syringe service piece this session. I'm probably using all the wrong words because I'm not a policy person, but and it was going to be a pilot. The thought was like, oh, well, let's just do it as a pilot and let's just do it in Jefferson County so that all these other politicians in Selma and Dothan, they're like, oh, that's fine. Jefferson County can have this. And that potentially, if it was successful and we had data to show, look how many overdoses we reversed, look how many HIV cases we diagnosed and linked to care, that potentially that data that would then lead to subsequent policy at a state level. But again, then COVID happened and we've seen public health officers just really be, effectively neutered in terms of policy. So not to be too negative, but that's kind of where I see it.
Thank you for the sobering news and your continued efforts to get it out there and whatnot. And hopefully with those continued efforts, you'll be able to slow and reverse those curves that you showed us. So thank you again. And I hope to see everyone next Thursday.
Thank you.